We would like to welcome Dr. Errol Gordon from Neurocritical Care for his grand rounds on targeted temperature management after cardiac arrest and neurological prognosis. Dr. Gordon received his medical degree from SUNY Downstate. He completed his residency training at the Medical College of Wisconsin, where he was also a chief resident. Dr. Gordon worked closely with trainees here at Mount Sinai as a neurointensivist. He is now clinical associate professor at St. John's Hospital at the University of Oklahoma College of Medicine. Please join me in welcoming Dr. Gordon.
Hi, everyone. Thank you. It's a pleasure being back, and it's a pleasure talking about a topic that has I have been involved with throughout my whole training. I have no relevant disclosures to this talk. So this is a quote from one of the earliest papers that actually started to look at neurological function after cardiac arrest. It's a simple statement. The comatose survivor of CPR poses a difficult ethical decision regarding life support measures when prognosis for survival and final outcome of neurological function was uncertain. Now, throughout my training, I remember before I decided to be a neurologist as a medical student, this was one of the sort of funny consults that you'd get as a neurologist, neurological prognosis. And I always felt that people sort of stepped away from these patients because, often they didn't do so well. Throughout my time in medicine, I've seen a lot of changes in terms of how we treat and manage them. And I'm going to give you a little bit of a background and a little bit of historical perspective as I go through the talk. Now, I like quoting this particular study because it's based in New York, and it also it was based out of St. Vincent Hospital, which is an old hospital in New York that's no longer around, which I did a couple of rotations at. Anyway, it looked at cardiac arrest in New York City over an 8-year period from 1986 to 1993. And what is striking is that the survival rate of all those patients, if you look, let's see if I get this. Look here, the survival rate with CPR was only 6.3%. Without CPR, it's only 1.2% in this population. This is, close to a natural history. And you realize that this is sort of like a very morbid thing, right? High mortality. And out of the 246 patients with bystander CPR, only about 39 of them made it into the ICU. And using the Glasgow-Pittsburgh performance, cerebral performance scale, which is sort of standard in these cardiac arrest patient outcome, you could see that only about 20% of the patients had a good overall recovery in the patients who actually made it into the ICU. So that's sort of like the baseline of what we have to work with in terms of cardiac arrest. Now, this was the actual study that I was referring to. This is back in 1977. The best I could describe it is it's sort of like a case control study. They took about 70-something patients. They looked at both survivors and not survivors, but people who are functional versus people who are impaired post-cardiac arrest. And essentially they did a neurological exam on all of them, and they tried to ascribe the different features, looking at the people who were comatose and look at the people who were impaired. Look at the people who were functional and look at the people who were impaired. And they drew some basic conclusions, right? The people who were more likely to be functional, their post-arrest coma was shorter, and essentially they woke up. Most of the people, if you're going to wake up, you woke up within 48 hours. And also the functional patients had better neurological examination findings, when they were able to examine them initially over here. But as a medical student and in the beginning part of my residency training, it was this study that kind of helped guide us mostly in terms of the prognosis. This is a study that was published by Levy, I believe in 1985. And essentially, they had a whole cohort of comatose patients. 210 of them were related to hypoxic ischemia. And they looked at those patients who had persistent coma, and they essentially did multiple neurological examinations at predefined time intervals. And then they did a multivariate analysis looking at the different features of the neurological exam that help predict outcome. And this is a summary of their slide. They tried to look for negative prognostic indicators as well as positive prognostic indicators. And for a long time, I think neurologists referred to this paper in terms of how you predicted outcome. This is sort of like where the 3 days, you looked at patients at 3 days, you looked to see if they had eye opening, you looked to see if they had a better motor exam than just decerebrate posturing, you looked to see if they had pupillary response, and if they didn't have any of those things, according to this paper, you would probably have a poor neurological prognosis. Then, in the midst of all these papers, there are these sort of, I like to call them as effect modifiers, right? Bystander CPR, automatic external defibrillator, and then targeted temperature management. And that these things sort of changed how we managed patients with cardiac arrest. The mechanism of injury to the brain, obviously, it's complicated. I'm not going to go through in much detail. Just know that you have hypoxia to the brain. It disturbs the blood-brain barrier. You have obviously reduced cerebral blood flow, cerebral edema. There's excitotoxicity. There's oxidative stress. There's activation of proteases and lipase. And by 2006, right, with the summation of all the studies, the American Academy of Neurology gave this handy flow chart and how to predict neurological recovery in patients post-cardiac arrest and coma. And this was pretty good, right? Basically, you would look for a poor prognostic feature, indicating feature, right? If they were in myoclonus, if they had status, if somatosensory evoked potentials, SSEPs, if they were bilateral absent N20s. I'm going to go over that a little bit more in detail. If their neuronal specific enolase was high, and this is in reference to the Levy paper, at day 3, if they had absent pupillary or corneal reflex, and if they were extensor in terms of their motor response. All those groups of patients had poor prognosis. Around this time, there was a lot of work on hypothermia in terms of cerebral protection, and and there's a lot of positive feature to hypothermia in terms of the world of neurology. I could attest in my fellowship in neurocritical care, I felt like half of the fellowship was learning how to make people cool for various reasons. You bring someone with mild hypothermia and it reduces the cerebral metabolic demand, it decreases the cerebral oxygen consumption, it decreases glutamate, which is an excitatory neurotransmitter, and it decreases the systemic inflammatory response. It stabilizes neural cell membrane and reduces destructive activities of these lipases and proteases and nucleases that cause damage. With all that, Peter Safar, who anesthesiologist who was instrumental in developing like CPR and resuscitative efforts. He did in the 1980s and 1990s, he did a lot of studies on dogs in terms of creating a model for cardiac arrest. And in this particular study, he essentially compared, he had a established cardiac arrest model, and he compared normothermia in a group of dogs versus hypothermia with augmented blood pressure support, right? And they had this sort of doggy behavioral scale. I guess most things to know about is the lower numbers are better. And as you can see with the group with the hypothermia and the augmented blood pressure, those dogs did better up to 96 hours, right? And the overall, after 96 hours, you could see that, in a statistically significant way, the group with mild hypothermia plus the augmented cerebral blood flow just looked more likely to look normal as dogs. And interestingly enough, right, they sacrificed the animals and looked histologically at the brain, the different portions of the brain, the neocortex, insula, hippocampus, basal ganglia, thalamus, and cerebral. They had less histopathological changes in the group with hypothermia. Interestingly enough, in the medulla, there wasn't any changes. There was no difference between the groups. So, the other thing that was sort of noted is that in places like the hippocampus, there may have been like a delayed effect, meaning that the injury, you maybe had a time window to affect a change before the injury was permanent. And with that type of thinking, I think in the the late 90s, there were a lot of studies looking at hypothermia in clinical patients to see if they could have a modification in outcomes. In 2001, this paper looked at 392 comatose, closed head injury comatose patients. And they were randomized to mild hypothermia, 33 degrees, and maintained for 48 hours. And interestingly enough, this was not, it wasn't a positive study. It didn't show to improve outcomes, which is sort of ironic because a couple of years ago there was another study looking at ICP and management with hypothermia, and it wasn't a positive study as well. But there was other kind of disease processes that people started looking at. This was from the people in Cleveland. The Kool-Aid study looked at cooling in stroke patients. They did a second study, but they never did a large study about this. But this sort of was around the same time, 2001. And then in 2002, there was 2 papers that were published in the New England Journal of Medicine at the time, which sort of changed practice. This first paper I'm talking about would be the Barnard Paper. It was basically a randomized paper, a randomized trial looking at patients in Australia that had VFib arrest. And they included the patients who had persistent coma, men greater than 18, women greater than 50. They eliminated people who had cardiac, who had shock, severe shock. And they were assigned to hypothermia versus normothermia according to the day of the month. All the patients had midazolam, all the patients were put on vecuronium. Hypothermia was obtained with ice packs, and they were maintained at that temperature for about 12 hours. And after 18 hours after induction, they would warm them up actively using a warming blanket. And what they showed was that the group with hypothermia had good outcome. And that was statistically significant. And when they even, when they stratified it for age and comorbidity, the statistical significance was even better. And then there was a study published by the Hypothermia After Cardiac Arrest group, the HACA group. And this involved, I think, 36, involved a large amount of ICUs in Europe. And they also included patients who had cardiac arrest related to ventricular fibrillation and non-perfusing VTAC. It was important to include people who had less than 15 minutes of time down without having bystander CPR, and they excluded people who had who ROSC was greater than 60%, 60 minutes. They also excluded people who had a temperature less than 30 on arrival. You had to be comatose, and that was really defined by not responding to verbal commands. And you also had to not be in severe shock, meaning that if you had a MAP less than 60 for 30 minutes, you were excluded, and if you had sat less than 85 for 15 minutes, you were excluded. And they also excluded people with terminal illness or known coagulopathy. Now, obviously the patients, the physicians or the healthcare providers were taking care of them directly, at least in the initial moment. They weren't blind, but the assessors of the neurological outcome were blinded. All the patients were sedated with Versed, fentanyl. They used pancuronium for shivering, and the grooms were randomly assigned to hypothermia versus normothermia, and for 24 hours. And they rewarmed patients over an 8-hour period. The primary outcome was looking for favorable CPC at 6 months, which was defined as CPC 1 or 2. The second outcome was overall mortality at 6 months. And as you can see, there was definitely a difference in the temperature of the two groups. But a lot of people commented on these patients here. There were a lot of them that actually weren't normothermic, they were febrile. But the outcome out of this study was positive, both for mortality and for favorable neurological outcome. You can see the survival curve here up until 2 days. And so after this, it was sort of like a race to develop these hypothermia protocols. Everyone, all these different societies updated their guidance in terms of treating people with hypothermia. But I think there were a group of physicians in Europe that were like, hold on, wait a minute, let's take another look at this. And in 2013, the targeted temperature management paper was published, and this was the largest study that was a lot more inclusive in terms of patients with cardiac arrest. And I think this changed a lot of people's views on how we should be treating these patients. I'm sure a lot of you are familiar with it, and I just wanted to say that this paper, right, does not negate the use of temperature management on patients, right? Both groups were actively managed in terms of controlling their temperatures, right? And so the issue is it's not. It doesn't say hypothermia doesn't work. It was looking at 2 different temperature parameters. Okay. So anyway, it involved 36 ICUs in Europe and Australia, included patients greater than 18. They specifically defined coma as a Glasgow Coma Scale of less than 8 or less. And the patients had to have had a witnessed cardiac arrest, and they excluded patients as well who had a temperature less than 30. These patients were randomly assigned to the 33-degree group versus the 36-degree group. The physicians performing the prognostications were blinded. All patients received sedation, and they used multiple different cooling devices in order to achieve the appropriate temperature. So the warming started at 28 hours, and they warmed people fairly quickly, and they kept people normothermic for about 72 hours, which I think is also important. The primary outcome for the study was all-cause mortality, and the secondary outcome, which is a little bit different from the other study, was looking at who were looking specifically for the bad outcomes. And as you can see here, I think the temperatures were much better in the higher temperature group, 36 group, was much better controlled than in the HACA trial. And the groups in general were, I think, fairly matched. And as you can see with this sort of survival curve, there is really no difference in terms of the survival between the two different populations. And even in secondary outcomes, the different populations weren't worse in terms of neurological prognosis. Now, I'm going to go through a lot of post hoc analysis papers based on this trial, just to kind of highlight some of the different nuances that were found. And I think what was important about this trial is that it included both people with shockable rhythms versus non-shockable rhythms, essentially people with VFib, VTAC versus people with just PEA and asystole. And if you look at this is sort of like a mortality curve between the two different groups. And you could see that there was really no statistically significant mortality difference between the two groups. And if you, interestingly enough, which is sort of not what I would have expected, maybe there was a little bit higher mortality in people at 33 with the shockable rhythms, but none of this was significant. In terms of kind of getting data for neurological prognostication, not all the patients in that group were able to have neurological exams. Only, about 168 in the 33 group and 145 patients in the 36 group. And this TTM study had already pre-specified criteria for poor neurological prognosis, meaning that it was okay to withdraw on patients if after 72 hours they had persistent coma, they had a GCS motor score of 2 or less, with the absence of N20s on SACPs, or in the presence of refractory status. It was also okay to withdraw on patients if they were in myoclonic status within 24 hours of the arrest and absent SACPs and 20s. It was also okay to stop if they were brain dead at any point, or if there were other ethical reasons that were sort of left up in the air. When we talked about the motor score less than or equal to 2, essentially we're looking at people who are decerebrate posturing or worse, okay? Anyway, so this is a little bit busy slide, but to me it's pretty informative, right? you know, decelerate posturing, pupillary response, corneal reflexes, right? The important, one of the important features of this is that being at 33 or 36, it made no difference in terms of it's these particular neurological findings being able to predict outcome, right? That's one thing. The second thing is that the sensitivity here, the best sensitivity was the decelerate posturing, but it had a fairly high false positive rate. Pupillary response and corneal response had a lower sensitivity in predicting poor outcome, but their false positive rates were much lower, meaning that if you didn't see those at 72 hours, they're more likely to have a poor outcome. And this is combining all the patients together, and I enjoy this slide because this actually looked at the timing of when you found these different features when you pooled everyone together. And you could see it at less than 72 hours in terms of decelerate posturing. The sensitivity was pretty high for finding poor prognosis, but again, the false positive rate was, I think, is obviously not acceptable. And the predictive power of these two findings, if you found these in patients, almost at any time period, had fairly good false positive rates, but the sensitivities were pretty poor. Just to sort of, this population may not, group of people may know what somatosensory evoked potentials are. Essentially, it's a way to test a pathway, the sensory pathway from different or large nerves peripherally. Essentially, you get stimulated like at the median nerve. That stimulation is tracked all the way up to the sensory cortex, and it creates a specific pattern at the sensory cortex using an electrode. Stimulating at the wrist here, you get this wave around 20 seconds, a negative wave, kind of on an EEG lead. And this is used a lot of time in surgery to help make sure that everything is going on in surgery. And in this particular population, it's a reflection of cortical injury. Absence of bilateral SCCPs have always been looked at, always been thought of as a poor prognostic indicator in cardiac arrest. And so, again, the importance here is that there is no difference in terms of the predictive ability for absent SCCPs in the TTM population that was studied. And again, also the sensitivity was not really good, but the specificity or the false positive rate was fairly low in this population. Even though, a false positive rate of 6% can be a little bit concerning when you're trying to decide whether or not to withdraw. Important features about SSCPs is it's relatively independent for sedation. That's why we're able to use it in surgery. And you could actually still have SSCPs in a patient who's sedated with an isoelectric EEG. You can still get the SSCP. So it's actually a good thing to have in these complicated patients. But if you were to sum up what you can glean from the TTM paper is that if you have bilateral or absent pupillary response or corneal response or bilateral abscess N20s on SCCPs, you essentially have a poor prognosis beginning from 36 hours after cardiac arrest, and that's irrespective of hypothermia. Just sort of like, when this paper came out, there was a lot of rush to judgment in terms of hypothermia doesn't work. But there was different opinions on why this paper was what it was, and initially I thought it was because there was a dosing effect that in more severe individuals you'd probably get a different pattern, and then they did this sort of post-hoc analysis that you would think that people who are down longer, who have more severe injury, the people with a colder temperature would have better benefit. And so they basically looked at time to ROSC. They divided it into quartiles and compared the outcomes between the two different groups, right? So what you found was predictably the people who were down longer had poor functional outcomes. But there was no significant difference between the two different groups in terms of the quartiles, in terms of how long they were down. Interestingly enough, right, and this maybe is more of a comment on our health system, women had a higher mortality rate, and it wasn't related to the effects of cooling. What they felt it was more related to the effects surrounding the cardiac arrest and how we treated women in the hospital. So, women were less likely to have cardiac arrest in public places. There wasn't a difference in bystander CPR, but if you're having an arrest at home versus out in the public, you're less likely to get automatic defibrillation, right? Also, though, they were less likely to get coronary artery bypass grafting and PCIs, which I thought was an interesting comment. As you can see, in all the different age groups, women had a greater mortality than men and had a worse functional outcome, and that was irrespective of the different temperature. The initial temperature also was also an important prognostic indicator, but the temperature itself wasn't the driving factor. People were more likely to have a lower temperature if their time to ROS was longer, and so it didn't really affect the mortality. Back to things that were more associated with predicting seizures. When I was taught, any seizure post-cardiac arrest would be a poor prognostic indicator, and that isn't really true. The incidence of clinical seizures, though, are about 30%, but even those people still have like 11% chance of a good outcome. Myoclonic seizures, though, which are more common, though, are indicates a worse outcome. And here, if you're looking at this population, you can see having a seizure, different seizure kind of activities. If you are in status, it would be a poor prognostic indicator. Different combined seizure types, even though sensitivity is low, it's pretty specific in terms of poor prognostication. And this is just sort of a survival curve commenting on that. EEG interpretation here is a very helpful tool in terms of prognostication. In the TTM population, they performed EEGs between 12 and 36 hours after rewarming, and they described it using a pre-specified classification. And what they were looking for were malignant and highly malignant features on the EEG, and wanting to find how that would predict outcome. And if you could see here, these are sort of what they described as malignant pattern. This obviously is a pattern where there is a suppressed background. This is a pattern where there is a suppressed background, but there are generalized discharges. This is what you would call a burst suppression pattern, and this is a burst suppression pattern with imposed discharges. All these would be considered malignant EEG patterns. And if you see those, those are highly suggestive of a poor outcome, at least in the TTM population. Neuronal specific enolases. This is sort of like a glycolytic enzyme that are found in neurons in the brain, and there are many studies using it in terms of using it to help predict poor outcomes. Classically, a level of greater than 33 nanograms per milliliters predicted a poor outcome. I have never practiced in an institution where this ever came back in time for it to make a significant difference in terms of predictive outcome. And in the few occasions that I had the information, oftentimes it was not as helpful as it purports to be, even in this population. In this TTM population, a third, the recommended at that time, the recommended level, it gave you a low sensitivity and a fairly high specificity, but oftentimes you'd see people talk about how people with higher values, they did well. But what was important to me, they checked NSC at 24 hours, 48 hours, and 72 hours. And almost all the patients who had poor prognosis had an increase in their NSC between one of the different time periods. And the people who tended to have a better neurological outcome had a trend towards decreasing the NSC in subsequent time periods. The same thing can be said with S100B enzymes. This is another enzyme that's in astroglial cells and Schwann cells. This is a study back in 2003, I believe, that looked at it, and they developed values in terms of predicting poor outcomes, and have no personal experience with it, but I imagine it tracks like neuron NSCs. Imaging in terms of predicting outcome. Now, this is sort of a poor DWI sequence, and you could see that the cortex is highlighted here. This is like a classic pattern in what you see in anoxic brain injury, and this is sort of reflective of the dog studies where there is specific injury to parts of the brain, the cortex, the little bit in the basal ganglia here as well. And this is sort of considered, most populations considered a poor prognostic sign. And the more sensitive it is, the more destruction that's happened to the brain. The European guidelines suggest checking this within 2 and 5 days. Here is a CT scan where you have complete loss of gray-white differentiation, and this also, most people seeing this would be a sign of a poor neurological outcome. I should say that sometimes people forget to do this, that when someone has a cardiac arrest and they're comatose, yes, a lot of times, or majority of times, the exciting agent may be the heart, but sometimes people could have neurological catastrophes like ruptured aneurysm that leads to cardiac arrest. And I think in all patients, before you kind of institute any of these things, you should probably get a head CT to rule out those findings. So how do we go about this, and how do we treat? What should a protocol look like, right? So I think that all patients with cardiac arrest, and if you're going to treat them, they all should be, their temperature should be managed, right? And it's up to you to decide whether or not you're going to go to 33 or you're going to go to 36. And regardless of the initial rhythms, as long as they're not following commands, I think If you're going to treat them actively, they should all have their temperature actively managed. It's important though that if you have a poor baseline or terminal disease, those are people you may decline this active treatment. If you have active or severe intracranial bleeding, you may choose to exclude people with traumatic etiology of arrest. People with cryoglobulinemia, probably you don't want them kind of clotting with cold, and people who are under 18. How do you set your goal, 33 or 36, right? I think that in most patients, you should try to go to 33. But if you are hypotensive or if there are other indicators that if you're concerned about bleeding, you should set the temperature to 36, right? If the initial temperature is less than 30, the patient should be actively warmed up to 33 degrees. If the initial temperature is between 30 and 32, you should allow them to passively warm to 32 degrees. Surface cooling or intravascular cooling is based on what's available at your institution. I know here, and I also have a lot of experience with the Arctic Sun, I think they work great. You can consider placing a central line and arterial line. I think that will help you in the management of these patients that are often complicated to manage. And you could also consider infusing cold saline to help reach the temperature that you want to select. You maintain temperature for at least 24 hours, right? But it's important, I think, to follow the idea of trying to avoid fever definitely for at least 72 hours. All patients should probably get Tylenol standing to help with shivering, and you can use a warming blanket, especially if you're using a device like the Arctic Sun. You place a warming blanket on top of it. I know it seems counterintuitive, but it helps with shivering. If you use a device like the Arctic Sun, its effect on lowering the temperature is much more powerful than the warming blanket, especially warming pads to the face and the hands. It fools the body thinking that it's warmer than it really is, and it reduces the ability for shivering. If they do shiver, you should kind of refer to a shivering protocol. And if patients have significant dysrhythmia, or if they start following commands, you could begin rewarming earlier. How far do we warm? This is sort of what's in the protocol here at Sinai in terms of rewarming, but obviously in the other studies, like in the TTM study, they warmed as quickly as 0.5 degrees Celsius per hour. This is sort of like a shivering protocol. Over here is the bedside shivering assessments tool. You could use this to guide it, and this is meant to kind of be a stepwise manner. Everyone should get Tylenol and buspirone to help out shivering. If shivering persists, you could do the surface counterwarming. There's a role for magnesium drip, and you could also use Diprovan or Precedex to help. Meperidine is excellent at controlling shivering, but it lowers the seizure threshold, so I often use it with caution. And finally, there's paralytics to help with the shivering during the cooling protocol. Sort of a little aside, and this kind of also goes back to the SAFR study that I mentioned. Oftentimes, right, you have a patient, they come in with cardiac arrest and their blood pressure is a little bit soft. And there are plenty of studies that show that an improved blood pressure improves your neurological outcome. This is kind of a retrospective analysis from an SCCM database showing that people with better blood pressures actually do better neurologically than people without. So I think that's an important thing to sort of track when we're actually treating these patients. It's also important to know that these patients may not be auto-regulating. This is a study that looked at patients, TCDs in healthy volunteers and compared them to cardiac arrest patients, and there was a suggestion that they were not auto-regulating, or at least there was a shift in the auto-regulation. This is another study at Cooper. They created this time based hypotension or a blood pressure scale, and as you can see, the people who were here, who were lower blood pressure, they didn't do as well, but there was sort of a peak effect of a mean blood pressure. And this is sort of like one of the things that we looked at here back in 2015. We actually used a device that measured cerebral blood flow non-invasively in the cardiac arrest patients, and we saw, they were pretty similar in terms of the different groups between survivors and non-survivors. But what we saw that people with a higher cerebral blood flow index, there was a 10. This wasn't statistically significant. There was a trend for the survivors to have a better cerebral blood flow. So I think it's important to actively manage patients. A couple of quick important studies that I just want to highlight, which I think is interesting. So they essentially replicated the TTM paper in children, and their primary outcome was this neurobehavioral score called the VBS-2. And in this population, again, there was no difference in both the neurobehavioral score and survival. This paper I thought was interesting. This replicated the original HACA study, and they kept patients cold for 48 hours versus 24 hours. And this, even though there was a difference, as you can see here, again, even though there was a trend to an improved outcome in patients who were kept cold for 48 hours, there was no significant difference. These two papers, I think, were also interesting in kind of like before the TTM paper came out. There were a lot of studies looking at starting hypothermia in the ambulance, the sooner the better, and that was a reflection to some of the dog studies as well. But in this study right over here, I think this is based in Washington. It showed that there was no improvement in earlier induction by EMS of cold saline, even though it did achieve the temperature of 34 earlier. It didn't show outcome difference between the two different groups. And interestingly enough, in this study, they actually tried to induce hypothermia while the person was in cardiac arrest, and did not show a benefit. And there was a tendency for patients who got the cold saline or they were less likely to attain ROSC. And that may have been a delay in kind of the appropriate ACLS care related to the study. So after all of this, right, I think this sort of doesn't fit how we should approach prognosticating. The European guidelines has this, which I think it's a little bit more messy, but it's important. It sort of includes more of the different features based on all the studies that we've had. And the idea of this is because a lot of these features don't have a very high sensitivity, you want to sort of group a bunch of different things in order to help you prognosticate. Use multimodal prognostication whenever possible. So it applies findings, neurological findings from way back when, from the Levy paper, and it takes into account whatever effects that may be with temperature management. I think in a way things are more complicated, but in a way things are a little bit easier in terms of prognosticating patients where we are at now. Anyway, I think that is my talk. Questions?
Mike?
So, do you have anything in your own mind that would tell you when the new patient comes to you, we shouldn't do anything, it's futile, or the prognosis is so bad, the patient's likely to stay in a vegetative state? Do you have any measurements that you can make that allow you to make that kind of distinction?
So when I am seeing a person shortly after they are resuscitated, right, what I'm looking for is any sort of brainstem finding, right? If I see some sort of brainstem finding, that I know that person is not brain dead, and if that person isn't brain dead, then I hold my judgment until I see them 48 or 72 hours. If there's absolutely no neurological findings initially, then in that patient, a patient that I highly suspect brain death in, those are the patients that I sort of move towards making that declaration. Caveat is if they have a CT that has global effacement, or they have this thing called pseudo subarachnoid hemorrhage, where the whole brain essentially is infarcted and you can see the outline of the vessels in hyperdensity. Those patients as well, I may tend to move towards just not being aggressive.
Any other questions? You have a follow-up?
Do you have any idea as to what other things might be done?
What other things might be done?
But, therapeutically, is there anything else that you can think of? For instance, we had somebody here, a neurologist, a number of years ago, who used to take people with subarachnoid hemorrhage and make them hypotensive. I'm not suggesting that it's good to take somebody with cardiac arrest and make them hypotensive, but I'm just pointing out that some people think out of the box.
So I think in the cardiac population specifically, I think sort of the thing that's important is like an intention to treat. I think oftentimes there's still a bit of nihilism, and I think making sure that you do appropriate critical care on them, until the prognosis is known. So you optimize their blood pressure, you control their temperature, you make sure that their electrolytes are okay. I think just the normal critical care goes a long way in terms of improving people's potential recovery.
Great, thank Dr. Warner for his talk. Thank you.